that's the future. I don't think we had those very well right now. We don't know which drugs work. We don't know which women are at risk. We do see that when a child takes a adverse effect from a fetal drug exposure, that there's a lot of variability, even around the same dose. We know dose is important. That's why we try to keep the dose low, and we're balancing the dose not to be too low to protect both the mother and child from the seizures, but not too high to protect the child from the anticonvulsant drug effects. All these drugs are teratogens, and teratogens, they have different risks for teratogenicity, like buvalproate being the worst. But there's evidence to suggest that they all have dose-dependent effects if you get the dose high enough. Luckily, for some of our drugs, like Lamotrigine, that effect is pretty small, and most of those babies do quite well in that regard. The hope in the future is that we will understand why there's this variability in the child and in the mother, and perhaps we can use genetic markers to inform us as to which women or children would be at greater risk for these teratogenic side effects. There's a whole host of other precision things outside of that we'd like to understand why some women have big clearance changes during pregnancy and some don't have any clearance changes. Most women have some clearance changes, but there's some. I've had occasional person, even with like Lamotrigine, which has big clearance changes, have none whatsoever during the pregnancy. And we don't understand the genetics that very well. There's one study from our group, showing that that these groups exist, and now we're trying to understand more about the genetics of that. So in my mind, for the care of women that have to take these kind of teratogens, understanding the underlying genetics, because we understand the dose part to a large extent, but we don't understand the genetic susceptibility part yet.